Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. So in conclusion, what are the overall concepts regarding the use of imaging and the use of multimodal CT? We know that non-contrast CT and IV thrombolytic therapy is still key within 4.5 hours and is the standard of care. We know that CTA can quickly identify a lesion without the need of creatinine, and a large vessel occlusion can often be demonstrated reliably with a CTA. We know that CT perfusion provides treatment guidance to experts when it is available as part of the neuroimaging workflow. We know that MRA and DWI are used for semi-urgent and unusual strokes, as in young patients. We know that if we can identify which patients will benefit from endovascular therapy, that this is key, especially because endovascular therapies are still underutilized in patients who have stroke and are evaluated in the acute setting. We know that the awareness of your stroke system will allow for optimal EVT triage, even with non-contrast CT alone. And we know that the AHA-ASA guidelines address AIS neuroimaging quite well. What are our conclusions about MRA and MR-DWI? We know that MR does detect microhemorrhage, but this isn't necessary. A non-contrast CT alone for detecting hemorrhage is okay. We know that MRA is no better than CTA because CTA is quite good at determining the site of a lesion in the craniovascular system. We know that CTP, perfusion, MR-DWI correlate well. And we know that MR-DWI perhaps is better for posterior circulation, lacunar infarct, watershed infarct, and small vessel infarcts that may present in patients with a low NIH stroke scale and low stroke severity. We know that there's probably no significant benefit to using MR to determine our MRA and MR perfusion with DWI, except with the cases that I just described above. And we do know that MR-DWI requires that the evaluation and testing be done in the subacute period, not in the acute period, unless there's the availability of MR Lite, which may be available in the acute settings of some specialized center with a 10-minute table time at an EVT-capable center. So what are our conclusions regarding expert guidance? We know that CTA and CTP provide information to experts, not the online emergency physician or other provider. We know that the clinical history and exam and the non-contrast CT with the aspect score and IV thrombolytic therapy are the key parts of acute ischemic stroke patient emergency care. We know that CTA and CTP do provide us more information to the experts regarding the importance of the time uncertainty, like with wake-up strokes, the possible use of IV thrombolytic therapy during a longer time window, such as up to 9 hours, the use of intra-arterial thrombolytic therapy using interventional techniques in EVT, and the use of EVT up to 24 hours based on the size of the core and penumbra with the ability to remove stroke thrombus mechanically. In essence, what the use of CTA and CTP or its MR partner, these provide a thoughtful discussion about what do you think, should this patient go to EVT, and might they have benefit related to the use of this 6 to 24 hour EVT approach. What do we recommend with regard to the treatment of patients with acute ischemic stroke and the use of multimodal imaging in the acute setting? First, quickly implement a stroke plan that includes non-contrast CT that is rapid and the use of IV thrombolytic therapy for the greatest number of patients during the 4.5 hour window. Next, a CTA should be obtained with a non-contrast CT when available without a lab delay for creatinine, looking for confirmation of the presence of a large vessel occlusion, which would direct patients to endovascular therapies. Next, use CT perfusion if you're able to, if it's present and available and feasible. If you're considering increasing the number of patients who may go for endovascular therapies between 6 and 24 hours, including intra-arterial thrombolytic therapy and or clot removal. This will maximize the number of patients who receive those additional therapies, knowing that the percentage now is quite low, and we can increase or grow the number who can have good outcomes as a result of the use of these additional therapies between 6 and 24 hours. You should learn your stroke system workflow, including EMS, what happens in the emergency department, and those intravascular radiology therapies that are provided by neuroradiology experts. You should also consider MRA and the use of DWI to determine the size of the core infarct and the ischemic penumbra, especially in those who are young or who have an unusual acute ischemic stroke presentations. And lastly, it is worthwhile offline to discuss the many 1A or best recommendations by the AHA/ASA regarding the use of imaging in stroke patients. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.